Recognising inflammatory back pain. An information resource for healthcare professionals in primary care to encourage a team approach. Brought to you by the Rheumatology Physiotherapy Service, an Iron Bevan Health Board, and supported and funded by Pfizer. The purpose of this presentation is to encourage a team approach to the management of inflammatory back pain, thus facilitating early diagnosis and treatment. Contents. The presentation will cover an overview of inflammatory back pain with a particular focus on the categories within spondyloarthropathies, including ankylosing spondylitis, and will later describe simple diagnostic and referral tools which may help improve performance in a team approach to clinical practice. The diagnostic algorithm was developed and is used by Sue Gurdon, an Iron Bevan Health Board physiotherapy, and is not endorsed or approved by Pfizer. Back pain. Scope of the issue. Back pain is something we deal with regularly in clinical practice, and it has been estimated that 60 to 80% of UK population report back pain at some point in their life, with figures ranging from 1/5 to 1/4 of all visits. It is reported that 5% of patients with chronic back pain have ankylosing spondylitis. Given the difficulties in differentiating chronic back pain from other forms of back pain, simple screening parameters could make onward referral easier. Common causes of low back pain. The different causes for low back pain are listed here. Mechanical back pain is often resolved or managed with physiotherapy and/or medication and quite often requires no intervention. All non-mechanical spinal pain should be considered for onward referral to the appropriate expert. Inflammatory back pain should be distinguished from chronic back pain disorders and other conditions. Inflammatory back pain, or IBP. We still know very little about the onset and pattern of inflammatory back pain. Symptoms may include deep low back pain, spinal pain, lateral thigh pain and buttock pain, and involvement of large joints. Inflammatory back pain may precede ankylosis. IBP. Relevant signs can include age at onset of back pain up to 45 years, peak age of onset 15 to 35 years, back pain lasting up to 3 months, possibly intermittent, night pain, early morning pain and stiffness lasting more than 1 hour, pain improves with exercise, tenderness, inflammation over SI joints, often seen as alternating buttock pain, insidious onset, often distinguishes from mechanical back pain. Early diagnosis is key for IBP, as it is the main symptom of the spondyloarthropathies. Spondyloarthropathies. Spondyloarthropathies, or SPA for short, form a broad category of autoimmune diseases. The two main subgroups are categorized according to whether the symptoms are predominant in the axial or peripheral regions. Enthesitis is the key to the inflammatory process, and the resulting abnormal bone formation can result in severe disability. They all share similar clinical manifestations and genetic traits, and absence of the rheumatoid factor is a common denominator. Ankylosing spondylitis is the prototype axial SPA. Ankylosing spondylitis is a major subset of the SPA diseases. Other major arthrotides are psoriatic, associated with skin disease, reactive, also known as Reiter's syndrome, enteropathic, associated with inflammatory bowel disease, and undifferentiated spondyloarthropathy. Although each condition has its own characteristics, there is significant overlap between them and one can evolve into another. Ankylosing spondylitis. Ankylosing spondylitis, or AS, is the major subtype and a main outcome of the SPAs. Inflammatory back pain is the major feature of AS, although large joints, hips, knees, and occasionally shoulder can be involved. Enthesitis is also a common complication and hallmark of the disease. Inflammatory features in the eyes, skin and gut can overlap with joint inflammation. The condition typically appears in adolescence or early adulthood. 90 to 95% of the patient population are HLA B27 positive. Another risk factor which predisposes a person to AS is family history, and therefore should be investigated. Epidemiology of AS. It is more common in men than women, although some suggest that women are underdiagnosed and the ratio is getting smaller. It is most common under 30 years of age, but also occurs in older adults. Estimates of prevalence vary between 2 and 5 per thousand. In 2006, there was an estimated 200,000 diagnosed cases in the UK. Prevalence also differs within ethnic populations. The mean diagnostic delay is around 10 years from onset of symptoms. Impact of AS. Pain and disability of AS can be similar to that of rheumatoid arthritis. Limitations in physical functioning have strong quality of life implications, with studies showing that 31% of patients with AS were unable to work due to stiffness, pain and fatigue. There is an increased mortality risk in AS patients compared to the general public. It is important to keep these patients fit and active. AS in women. Historically, AS has been seen as a disease that predominantly affects men. However, recent studies suggest that the gender preference is less pronounced than previously thought. Furthermore, women were found to have significantly earlier age of disease onset, worse functional outcomes, and more women had positive family histories. Reasons for this may include radiographic evolution is slower in women and radiographic severity is worse among men. Women tend to have more peripheral disease. The delay in diagnosis may be due to the lack of recognition of the disease in women, and the phenotype of the disease tends to differ. AS-SPA is associated with comorbid manifestations. Diseases belonging to this group of arthropathies are linked by common genetics and pathology. Apart from spinal manifestations, these diseases are also characterized by comorbid and extra-articular manifestations. Features include peripheral arthritis, enthesitis, uveitis, dactylitis, psoriasis, Crohn's disease and ulcerative colitis, family history of spinal arthritis, HLA-B27 positive, lung, heart and kidney disease, and elevated CRP levels. The articular and extra-articular manifestations associated with SPA can have a huge impact on a patient's quality of life. This highlights the importance of recognizing and treating comorbid conditions in patients with AS. AS and enthesitis. Enthesitis is inflammation of the point at which a tendon or ligament or muscle inserts into bone and can occur in approximately 1/3 of AS patients. Clinically, swelling of the tendon or ligament insertion results in painful and tender lesions and can occur in the spine and peripheral sites. AS classification criteria. The 1984 modified New York criteria are commonly used for disease classification. It combines clinical and radiographic criteria, and a patient is diagnosed with AS if the radiological criteria is associated with at least one clinical criteria. AS diagnostic challenge. The diagnosis of AS is hindered by the fact that many classic features, such as low back pain, are not specific, and therefore irreversible damage is often present at time of diagnosis. As there is a diagnostic delay on average between 8 and 11 years, timely intervention is important to reduce the impact of the disease. Differential diagnosis of AS can be difficult due to symptoms being confused with back pain or injuries, particularly in fit, active adults. Numerous tests are required to confirm a diagnosis, less pronounced clinical features, and possible slower progression of radiographic changes. Earlier recognition of AS is becoming more important as effective treatments have improved management of this disease. Red flag considerations. Persistent severe back pain and restriction of lumbar flexion may result from more sinister pathology. The differential diagnosis of AS should exclude cancer or tumours, primary tumours are rare, bacterial infections, metabolic bone disease, osteoporosis. Development of a diagnostic algorithm. There is an unacceptably long delay between the onset of symptoms and time of diagnosis for AS, and the longer the diagnosis is delayed, the worse the functional outcome may be. 5% of patients presenting to the GP surgery with chronic back pain will have AS. To optimize diagnostic accuracy of early AS, a comprehensive approach is crucial, with an understanding of the disease and its clinical picture. Appropriate physical and medical therapies can lead to complete symptomatic remission in a significant number of cases. How to make a diagnosis. Symptoms can be evaluated using the following diagnostic reminders. If the criteria for IBP are present, a thorough history of the symptoms and family history could provide further suggestions. Restriction of movement is not always evident in the early stages. Enthesitis can produce tender areas around the pelvis and lumbar spine, and occasionally the thorax, ribs, and costochondral areas, so spinal examination may also facilitate diagnosis. If AS is suspected, refer to rheumatology services. Diagnostic algorithm. Early recognition and treatment are the forerunners to good management of this disease. This algorithm shows the criteria and characteristics to identify inflammatory back pain guide and appropriate management. This is the diagnostic algorithm developed and used by the rheumatology department at Aneurin and Bevan Health Board, Physiotherapy. As such, it is not endorsed or approved by Pfizer. Secondary care pathway of Aneurin and Bevan Health Board. Once diagnosis is confirmed by the rheumatology consultant, patients will be referred to a specialist physiotherapy clinic. The progress of the disease will then be monitored and managed by the specialist team. Treatment will be individually tailored and patients will be guided towards the most appropriate management strategy. Key messages. Early diagnosis of inflammatory back pain, IBP, has proved to be a challenge and can present similarly to other causes of lower back pain. Presentation of SPAs can be subtle, particularly in the early stages. The early and accurate diagnosis of AS can lead to better outcomes for the patient. Referral should be considered in all patients with features suggestive of IBP. The main value of history and physical examination is to determine which patients should be referred for further evaluation and may facilitate prognosis. In Aneurin and Bevan Health Board, all patients with features of IBP are referred to rheumatology services who provide differential diagnosis and optimum care by an expert multidisciplinary team. For further information, these professional and patient bodies have agreed to supply further information should you require it. Please click the desired logo for contact addresses.